experience. I'm a dermatologist in Boston area for 22 years. I'm originally from Karachi, and I travel all over the world to present my experience. But the most pleasure I get on any of these presentations, and I come back to Pakistan and share my experience. I'm going to talk about acne scars and use of lasers a little bit. So there's a lot of overlap that always been covered by this wonderful talk. So I'll try to go quickly through that and then move forward. These are my disclosures. As we just heard, the acne is the most common skin disease in the world. Almost everybody has it. It's a defect of keratinization and the disease of pilous sebaceous unit. When we get stasis there, we get pre-acneous infection, and then we have to treat all of that. The different kind of acne, comedonal, papular, pustular, nodular, and cystic. And it could be comedonal acne, papular, pustular, it could be also acne conglobata. The scars can happen actually to any kind of acne, but more common with nodular, cystic, and acne conglobata. Types of scars we get, we already saw that, the ice picks, rolling box scars, we already saw this photo. So how do we treat that? As you just heard, in any treatments, what we are doing now is a combination of different treatments. There's no one magic wand that we use and every individual can be treated like that. Each individual, each scar is different, and we have to customize the treatment to it. So punch grafting or elevation, chemical peels, fillers, dermabrasion, sanding, lasers, radiofrequency, microneedling, rollers, and a combination of all of these can be used. In terms of lasers, non-ablative lasers and IPL, almost virtually any laser has been used for that purpose, but the results are not really that great. And the new kid on the block is pico laser that's been used for acne scars, and I have some photos of that too. And obviously ablative lasers that we've been using for years, CO2 and Erbium, which is now both of them available in fractional modality, and I've been using those too. The punch elevations, we also have to, if the scars are longer, we do excisions, subcisions, and laser resurfacing. So the punch removal or punch elevations, when do we do that? We can do immediately before we do the resurfacing, and we can do a few weeks before that. What happens is, if the scars are too closed, and if you do punches next to each other, and you put the sutures in, they're going to pull on each other, and the scar gets widened. So it's better to do a few at a time, and once the punches are done, then you can do the resurfacing. Typically what I do is do about 3 sessions of these punches, and when I do the last one, I do resurfacing at the same time, making sure that I'm not going to melt the sutures. And the punch sizes could be depending upon the size of the deep acne scars, and the suture I use it typically 5 or 6 protein. And some hypertrophic scars, long and linear scars, we have to do excisions. I'll show some photos of that too. Subcision is done immediately before resurfacing. You have to use local anesthetic for that, it's quite painful. And typically I use an 18-gauge needle, and you do subdermal undermining, which also stimulates collagen synthesis. This is how typically it's done. With the 3 cc syringe and 18-gauge needle, you anesthetize the area and keep your hand on top of the skin and just move back and forth like liposuction cannula, and you can break the scar tissue like that. When we do ablative resurfacing, we have to use local anesthetic. When I was doing full ablative resurfacing, I used to inject lidocaine intradermally before resurfacing. Now with fractional devices, I use a triple anesthetic cream for about half an hour. I also have a device of nitrous oxide gas We give that to the patient and we do the treatment. They still feel it, but a lot more comfortable. And when we are doing the treatment, we have to choose a few parameters that are very important, how deep or how superficial the treatment is going to be, which will result into what kind of end results you want to achieve. So spot size is one, fluence obviously, what kind of energy level you're trying to use. You can also customize that for different areas of the face. If the scars are very deep, you want to use higher energy. If in some areas they're not deep, you can use lower settings. The repetition rate is important too. If your repetition rate matches the speed of your hand, with that you're moving your handpiece, it's fine. But if you're moving too slow, you're going to overlap the pulses and get into problems with that too. And obviously number of passes, depending upon how deep the scars are, one pass may be enough, but we have to do the second pass. One caution here is that we don't want to do what's called stacking the pulses, not one pulse right after the other one. Why is that? Because if you keep doing this, you're going to end up with the scars. Because your chromophore for both these ablative lasers, Erbium and CO2, is water. So when you hit with the first pulse, you bleach the water. Your chromophore is gone. Now, to get the chromophore back, which is water, you have to wait 20 seconds in between. But if you don't wait and keep hitting it, there's no water and the target is not there, energy goes into collagen and you end up with scars. In general, with acne scars, we can get an improvement of 30 to 80%. When we're treating wrinkles, 50 to 80%, and it really takes 6 to 12 months to see the final results. Complications, most common is pigmentary alterations, infection and scars. All of these are rare. One thing is a lot of laser companies, RF devices claim that they are colorblind because their energy is not absorbed by melanin, which is true. But whenever there's inflammation, no matter how you do it, there's always a possibility of PIH, post-inflammatory hyperpigmentation. Even if you start scratching your hand in our skin type, mostly skin type 4, we end up with hyperpigmentation. A lot of you who fry samosas and you see a drop of oil gets on your hand, that leaves a dark mark. It goes away, but it takes a while. So any device, any modality that you use, whether it's chemical peel, punches, RF, laser, you can get these pigment problems. A couple of patients here. This patient, as you can see, has very deep scars here. Not one single treatment modality would fix it. So all these deeper ice pick scar, I removed them. It took me about 6 months to finish his treatment, and then we did the resurfacing, and this was 6 months after that. And he was supposed to come back for another resurfacing. He went back to Cambodia and hasn't come back yet. This is the other side. This area here, obviously we cannot do punches because we don't have not much skin to pinch. But all these here, all of these deeper ones were punch removed, and then we did the fractional CO2 resurfacing. As you can see, he's also skin type 4, but there's no PIH. This is just the resurfacing. Her full face, I treated her full face, not just this part here. Sometimes to get even results, especially if the patient is older, it's better to treat the whole face. So you get improvement in the skin tone, texture, pore sizes, acne, and acne scars. This is just CO2 fractional resurfacing, and you can see that her scars are much better, but look at the skin tightening and how skin texture is much improved after the treatment. These scars were not treated with ablative lasers because these are erythematous scars. So I used the pulse dye laser. She had 2 treatments. We could have done more improvement with this, but she was happy with the results of that. Here's some linear scars. Where this one here, I excised this first, and then we did the resurfacing one. He also had a couple of treatments. He comes back every few years to get another treatment. Same thing here. Several scars here were excised, and some punches, and then finally resurfacing. This is just resurfacing. Same here, this deep scar here were excised in some punches and resurfacing. This patient, as you can see, this hypopigmentation here, he was sent by another doctor who did dermabrasion on him twice, and he said the scars did not get better, but he ended up with this white patch here, and then we did some punches and resurfacing, and this was 6 months after that. Obviously not everything is gone, but much better. This is pico-wave results, not my patient, Dr. Friedman's patient, and you can see some of the scars here, and after 2 treatments. This is also pico-wave, same thing here, scars after a couple of treatments. You can see the improvement with this too. I think we have to learn more about pico lasers, see how they are more useful, not just in tattoo removal, but other indications as well. Pigment removal, acne scars, photo rejuvenation, and everything. Can I finish in the video? I finish? Thank you.
Thank you.
Yes.
Can you show the last slide, sir? Yeah. The next one.
It's working.
So how many sessions you have done for this patient
The
to give this
preliminary.
result?
It was not my patient. My guess is it's 3 treatments, because typically the treatment is 3 treatments with 1 month apart.
1 month apart. So what is the downtime for such a treatment?
What is the down?
What is the downtime?
There's 0 downtime. With pico, if you're treating acne scars, you may get some redness that can last about 6 to maybe 12 hours, and that's it.
So is it any post-care that we need to ask them, as we ask the patient when they are done with the CO2 laser, that they shouldn't be exposed for next 10 to 15 days in the sunlight?
With pico, no, we don't have any specific post-care, except obviously if it's dry, moisturized, it's the most important is the sunlight.
Every pico laser that is available in the market, do you think they are authentic? So
No, there are pico wave lasers and pico wave lasers. One I have experience with, it has the shortest pico wave pulse duration, which is pico wave. It's 450 picoseconds. Most of them are in 700 picos. Dr. Nashua has personal experience with that.